Well, welcome everybody. It's wonderful to see so many people here today. I'm Miguel Reguera. In a minute, I'll let my panelists introduce themselves. For those that are still trickling in, there are a few seats up front, but it's wonderful to see so many in the room. And we have over 800 people registered online and out virtually to the country. But for those in the room, as indicated, this should be very interactive. Please use your iPad. We'll try to answer as many of the questions as we can get to. So as you know, this is in support of improving care. CME Outfitters is jointly accredited. I won't read through the whole slide, but this is a program where physicians and nurses, APPs can get accreditation for the program at the end. There will be a CME and mock accreditation. So toward the end, we'll have a QR code and you'll have a chance to actually get your credits. The activity may include discussions of products and devices that are not currently labeled by the FDA. We will try to avoid that as much as possible, and if we do deviate from that, we will also disclose that as well. As mentioned, the iPads are going to be your way to ask questions, so whether you're online or whether you're in the room, we won't have mics in the room, we'll just use the iPad. Feel free to put the questions in. I'll do my best throughout the program to get to as many of them as possible, and certainly at the end, we'll leave time as well. So I'm Miguel Reguera. I'm the chief of the Digestive Disease Institute at Cleveland Clinic, and I'm going to go down the line and let my panelists introduce themselves. Anita, starting with you.
Absolutely. Well, welcome and thank you. Good afternoon. Pleasure being here with my colleagues. I'm Anita Afzali. I'm a professor of medicine at the University of Cincinnati and currently serving as the interim chair of the Department of Medicine. Dr. Barnes?
Yes, hi. Thanks, Anita. I am Ed Barnes. I'm at the University of North Carolina at Chapel Hill. I'm an associate professor of medicine, and I am the co-director of the IBD Center as well. So now I'll pass it over to Angelina to introduce herself.
Hi, I'm Angelina Collins. I'm a nurse practitioner at the Inflammatory Bowel Disease Center at University of California, San Diego.
And also part of the program, not in the room, some of these folks are actually at this conference, but they're not actually in the room. This will be a unique program, and I'll come back to this in a minute, but Jessica Allegretti will be highlighted, Ed Loftus will be highlighted, as well as Millie Long. And I think more and more in the world of inflammatory bowel disease, we're trying to include patients and patient voices and stakeholders. So you'll hear from a couple of our patients. They've been active in many of the programs like this at the Congress and others, and it's really a treat to have both Natalie and Kayla today as well. These are our faculty disclosures. They'll also be in your program. Each of us have listed our potential conflicts of interest in our disclosures here, including Jessica, Ed, Millie, Natalie, and Kayla as well. This is also a peer review program, and this goes through the traditional CME vetting. So the learning objectives will be to integrate the latest data and recommendations on IL-23s into your clinical practice and to come up with treatment plans and a shared decision approach with patients. And as a minute, I'll get to this, but this is a very case-based presentation. We'll also look at the latest clinical trial efficacy and safety data and utilize the latest in clinical evidence. So this program, just to break it into how this will look, the first part will be a very brief didactic program. I'll go through the efficacy and safety data with the IL-23 class. I'll engage my panelists after both the ulcerative colitis and Crohn's portion. But then really the meat of this, which I think is unique, and we'd love your feedback at the end, is we have 3 wonderful cases that are very real world. We show the couple of the patients who are involved in this. Now we have adjusted at their permission some of the case to also stimulate some of the discussion. For me, these are cases that I would see in my own practice in Cleveland. I imagine for all of you, you would see them. I know our panelists have vetted these as well. And this will stimulate a conversation on the cases that I think will be informational as well. So I'll go through some of the didactics here. The treat to target precision care, you know, we've really evolved in the way we've looked at treating both on the left-hand side ulcerative colitis and Crohn's disease on the right-hand side. A theme that I'll mention up front is the early treatment with advanced therapy for both ulcerative colitis and Crohn's disease. This will be a concept you'll hear repeatedly. I know you've heard this in the last few years. You're hearing at the Congress there. But your first therapy early, it's probably the early use is going to be most important. But we'll go through some of the patient characteristics. Access is obviously something that we all live with, and especially the United States, in terms of if we can't access something, that's a barrier. So that's something that we recognize. And then obviously efficacy and safety. Why is the interleukin-23 class important? I remember some of the early GWAS genetic studies where we identified IL-23 as a putative factor in inflammatory bowel disease. It leads to a pathogenic Th17 response. It promotes inflammation. Interestingly, increased IL-23 also may predict resistance to TNF inhibitors. This needs to be borne out in clinical studies, but that may be why some of our patients don't respond to a TNF inhibitor, but do respond to an IL-23 inhibitor. We'll get into the selective IL-23p19 class and go through some of the efficacy and safety. I like this slide because this puts all of the pivotal trials that have been done in interleukin-23s on one slide. In the blue lettering are the ulcerative colitis pivotal trials, and these are the regulatory trials that led to approval of the IL-23s in ulcerative colitis, and kind of in the dark black is the Crohn's disease. And you can see we'll discuss risankizumab, guselkumab, mirikizumab. We'll show the data, and I think one of the nice things, and we'll get to this in a minute, you can take this information with you afterwards. So as mentioned before, there's a lot of data in the first set, but this is something that we really want for you as well. Whoever's controlling the timer in the back, it didn't start, so maybe count me down so whatever the difference is to now get to 30 minutes. So these are busy slides. I'm not going to present all of these, but this puts into context, and people often say, to put the data together, guselkumab and mirikizumab on this slide. You can see the FDA indications are for all of them, ulcerative colitis and Crohn's, but you can see the route of administration, and we'll get into some of the differences of that when we have our panel discussion here in a minute. And then also the efficacy. On the right-hand side, you can see the different efficacy. Again, it's not meant to compare across each of them, but to give you a sense of efficacy. And I'll say up front that the efficacy of these looks similar, but we can't say that in a comparative effective approach. This is risankizumab, ustekinumab. We'll focus primarily on guselkumab, mirikizumab, and risankizumab. We'll talk about ustekinumab and some of the pivotal head-to-head comparisons, but we're not going to focus on ustekinumab. But if you have questions about ustekinumab, we can certainly do that. Safety, I think you've realized this, and many of you have prescribed these medicines already, to realize the safety with the IL-23 class has been quite good. But you can look at the serious infection rates are quite low, similar to placebo. The most common adverse events are listed. Monitoring, which usually TB screening, and we do baseline testing for LFTs, then after induction. That's very similar really for all of them. And then finally for Crohn's disease, again, same thing, looking at guselkumab, mirikizumab, risankizumab, far right, ustekinumab. Also safety in Crohn's disease looks quite good, and there's nothing new today in terms of safety we're going to present to you that you have not already seen in the publications and in some of the pivotal presentations. Let me briefly go through some of the ulcerative colitis data, and then I'll go through, I'll ask all of you in terms of what your thoughts are at a high level. So we'll go through each of the IL-23s, we'll present the data, and as I mentioned, we'll do ulcerative colitis first, then we'll do Crohn's disease, and then we'll get to the cases. So let's look at clinical remission and endoscopic improvement. So this was the QUASAR study, and this is the guselkumab induction for ulcerative colitis study. You can see in red here is guselkumab, the 200 milligram IV dose at 0, 4, and 8 weeks, then looking at the 12-week endpoint from left to right, clinical remission, symptomatic remission, response, endoscopic improvement, and HEMI, histologic endoscopic mucosal improvement. And you can see for each of the endpoints, statistically higher efficacy of guselkumab compared to placebo in that induction course. And then we look at the maintenance, the week 44 endpoints, and the reason there are two red shaded is that's guselkumab sub-Q every 4 weeks, which is one of the FDA-labeled maintenance doses, or the lighter red, the 100 milligrams every 8 weeks subcutaneous, and then again you can see placebo. And you can see the primary and secondary, major secondary endpoints were all met. I'm not going to read through all of them on the bottom, but you can see these were all met for ulcerative colitis. One thing that comes up, and I'm sure it comes up in your own practice, is what if a patient's naive to therapy, or what if a patient's who already been on an advanced therapy? How do these medicines perform? So this is the guselkumab study for previously treated patients with ulcerative colitis. On the left-hand side is naive. So that's a patient where guselkumab in the QUASAR study was the first therapy the patient received in advanced therapy. And as we've seen with our other studies, you can see a nice delta between the red bar, guselkumab, and the darker bar, placebo. And then what about patients who've been on maybe a JAK inhibitor or another biologic? Still statistically significant, although barely met with one and a lower response, but still we see a difference between guselkumab and placebo. I think one area of guselkumab that you've probably all realized now is that there is a subcutaneous induction. So you use subcutaneous induction followed by subcutaneous maintenance. And this is the ASTRO study. This is looking at subcutaneous guselkumab induction for ulcerative colitis. Again, on the top are bio-naive, bottom are bio-experienced. And interestingly, when you look just kind of visually at the bottom, subcutaneous, there's no drop-off, meaning using subcutaneous induction, and I'll ask my panelists whether they're using IV or sub-Q for both ulcerative colitis and Crohn's induction, but you're seeing good efficacy with subcutaneous induction. Now, subcutaneous induction is 400 milligrams, which is 2 times the 200 milligrams IV. So just pharmacokinetically, it's double, but it's still given at 0, 4, and 8 weeks. Mirikizumab, also the data in ulcerative colitis. This is LUCENT-1. Mirikizumab, you can see in blue, the dose is 300 milligrams, placebo in gray. And again, you see a nice statistical efficacy, mirikizumab compared to placebo. On the right side, an a priori endpoint was bowel urgency, and you can see kind of the separation of bowel urgency, meaning the improvement of bowel urgency as an endpoint with mirikizumab over the first 12 weeks. Maintenance with mirikizumab for ulcerative colitis, the LUCENT-2 study, and you can see again from left to right, and the blue compared to placebo, and again we're seeing statistical efficacy of mirikizumab for the treatment of ulcerative colitis. And then finally, risankizumab in ulcerative colitis, it's called the INSPIRE study, and this, the purple is risankizumab, the gray is placebo. The left-hand side is looking at the clinical response and remission rates at week 12, which are the primary endpoints. And then you can see on the right-hand side the ranked secondary endpoints, again, statistically significantly met with risankizumab compared to placebo. And then looking at the maintenance for ulcerative colitis with risankizumab, similar theme. For risankizumab, as you know, there are 2 different maintenance dose options. So on this slide, the light purple is 180 milligrams every 8 weeks sub-Q, now given as an on-body injector in clinical practice. And the dark purple is risankizumab 360 milligrams. And you can see both of those were statistically significantly higher than placebo for most of these endpoints. So before we pivot to Crohn's, and maybe Anita, I'll call on you first. It's a lot of data, but your overall impression of ulcerative colitis, IL-23s, maybe start just to kind of give your thoughts on that.
Yeah, so I would say overall, the data is really great to see. We're finally seeing numbers. We've been talking for the longest time about hitting that therapeutic ceiling. And now with this kind of endpoints, really stringent endpoints, both clinically as well as endoscopic, and we have histologic data for ulcerative colitis, it's really great to see this level of efficacy and durability as well, especially for ulcerative colitis. I also want to highlight, Miguel, for example, with the guselkumab, we had the sub-cohort analyses, and these were also patients who were previously exposed to JAK inhibitors. And with the timing of when guselkumab was approved, we had more patients previously on a JAK inhibitor as well. So this is very telling that we're seeing these type of efficacy results, even among patients who were previously exposed to a JAK.
Right, so not just the naive patient,
That's right.
not just the previous biologic, but the JAK inhibitors. Ed, let me ask you a question about the subcutaneous. So, going back to, and I'll date myself, I came out of training in 1997, and infliximab came out shortly after that, and we always thought you had to use IV therapy for induction. IV was better than any other modality. Yet for ulcerative colitis, we're seeing pretty good data in the Astros data with sub-Q induction with guselkumab. One, I guess that does surprise you, and what are you doing in your own practice?
Yeah, so I would say it is a little bit surprising because it's counterintuitive to what we think about ulcerative colitis, where we think about the mucosa being leaky, and in really sick patients, think about acute severe ulcerative colitis coming in with a low albumin, and we're making a decision about are we even going to use an anti-TNF because they're losing protein across that barrier. So I think it's a really good question. The data would suggest, in terms of those clinical remission rates and the endoscopic endpoints that Anita mentioned, that we're not supposed to compare study group to study group, but if you just think bar graph to bar graph, you're getting those same rates of remission at the same endpoint. So I would say, to answer your first question, yes, I think it is believable that we can achieve the same types of remission and the same type of outcomes that are sort of matched using a subcutaneous induction regimen. And so, to answer your question, the second part of it, we have transitioned to patients using sub-Q in UC as well for two reasons. One, I think logistically, at least for us at UNC, it's hard to get patients into an infusion and to get them into an infusion in a rapid chair. You have to go through the process of getting them a chair, getting the insurance approval. I think that's a really important point. And then secondly, you can know that your patient's leaving and when they're going to get on a drug, and that timely induction, as was mentioned on one of the first slides, is really important.
And then, Angelina, I guess, you see a lot of patients as an APP. They often come to you first and ask about safety and education around safety. And although I showed it in the table, I didn't present it necessarily in the additional information. But talk to us about, ustekinumab obviously everybody knew that was very, very safe. What about the IL-23 class? Anything additional? And what are you actually telling your patients in the clinic?
Yeah, it's a great question because you're right. I mean, I like to pair the conversation of efficacy with safety at the same time, right? You can't talk about one without the other. Your patient's probably thinking more about safety up front, to be honest, in many ways, unless they're really sick, and that's the easiest of the conversations we could ever have is with the super sick patient. They're like, just make me feel better and I'm good. But I think the safety conversation is quite easy, relatively speaking, for the IL-23 entire class, right? For those people who have been exposed to an IL-12/23, I think it's particularly easy because you can say there's not really a difference in safety, with the exception that we're just going to be monitoring, for the medications, we need to be monitoring liver enzymes, right, for hepatotoxicity. So that may look a little bit different, but in reality, in my practice, I'm practicing the same way that I would have anyway. I'm getting baseline labs at the beginning. I am monitoring at a certain point to see that the patients are responding anyway. And I was doing this already, honestly. They may not have understood what I was, exactly the rationale that I was doing to check both are the labs looking better than they did initially? And also you're looking for the safety as well. So that all really looks the same. And to me, I feel equally reassured that the real things that matter, that there's not an increased risk for cancer, for example. I think that's really helpful. There's not an increased risk for lymphoma. Very helpful to be able to state that to your patient because they're worried about cancer. And then the serious infection risk being very low, that reassures me and hopefully as well as the patient also.
Yeah, I think you and I practice very similarly, and I think the safety with these is excellent. I think probably you as an audience that are using these see that. I do the same thing pretty much with all of our therapies where I will do baseline I usually get a CMP and CBC, but a baseline LFTs and then after induction. I have in the IL-23 class, as Angelina mentioned, seen some of these patients have a transient elevation in AST and ALT. And if I see that after induction, it does prompt me to not say, let's wait 6 months to a year to get another set. Probably within the next couple of months, we get another, just to make sure that's not going up. Before I go on, there are a couple of questions. I'm going to ask you first from our virtual audience, Anita, kind of the best candidate or positioning of the therapies. The question was best candidate for guselkumab, but how do you position these three in ulcerative colitis? And then Ed, there was a question about bowel urgency, which I mentioned with mirikizumab. Is mirikizumab the only one that has that, or are there others? So Anita, you first in terms of positioning of the three. Obviously, they all look good. How do you decide?
Yeah, so overall, the best candidate is the patient in front of you, and you have to look at the factors that are associated with that. It comes down to several factors. I think we're seeing efficacy here as outlined, but certainly recognizing that there becomes the patient preference. We talked about the IV induction as well as the sub-Q formulation. And with guselkumab, it's the only IL-23 that allows that has the formulation of the sub-Q. For many of us, I'm very fortunate to have an entire team work through that whole process for me, so I don't deal with that stress. But for the convenience factor of going through the authorizations, for getting the IV and then the sub-Q and all of this, it's probably that easy button, Miguel, that I think that it's also not only the patient preference, but potentially also the prescriber preference to have that easy button. You want to start an IL-23, and you want the convenience factor as well.
Yeah, so the take home from Dr. Asfali is the easy button. And, quote, I don't deal with that stress.
Yeah, I can't have wrinkles. Come on.
Yeah, well,
I need.
That's a take home for me. All right. Ed, let me ask you a quick question, then we'll go on. There are a lot of great questions coming in. Keep them coming. And we'll try to get through as many of them as we go forward. But bowel urgency, mirikizumab, I showed the data. Do the others have that? Maybe speak to that.
Yeah, so I think it's a great question because bowel urgency is among the, if not the most critical symptom that your patients will have. And I think the reason that the mirikizumab data is really important is because if you're like me in clinic, you can talk to your patients about, do you have bowel urgency? And they don't say, yes, my urgency numeric rating score, which I'll tell you in a second, is a 7. They say, I can't make it through a meeting, or I can't make it through my commute. And so we now have a way to quantify that through the mirikizumab trial program. So Miguel showed you that curve that fell off compared to placebo. And so that was the urgency NRS. And so that's why I think you saw that rapid drop in urgency. So that's something that's really important to know about mirikizumab. But it's not the only even IL-23 that has data for urgency. Hidden in one of the other bar graphs on the risankizumab, you saw a large improvement in patient-reported urgency scores as well in the risankizumab data. So I think probably a lot of our therapies will help urgency because they're helping the patient's symptoms of ulcerative colitis. But I think the mirikizumab program did a really nice way of quantifying this so that we can track it over time and not have to ask some of these, questions that are really important to patients, but then we can quantify it in a clinical trial program.
Yeah, I think the mirikizumab had a numeric score that was developed, and they implemented it a priori as an endpoint. Just to be clear, as Ed said, the other IL-23s have either post-hoc data or data that do show improvement in bowel urgency. So it's not maybe specific to the IL-23 mirikizumab improving urgency. It was measured a priori, which I think was really good, well done, but probably all of them do that. All right, let's finish out the didactic presentation. And Anita, when we get to the end of this, I'll talk to you because I know you were one of the primary authors on Galaxy. So this is, now we're switching to Crohn's disease, and this is guselkumab induction in Crohn's. I'm going to point out two things here. You'll see different induction doses with the different colors of red. I will say that the light pink is the 200 milligram, which is FDA approved, but you can see the higher doses didn't have any additional improvements. So this is why the FDA chose the 200 milligram, which is what we use for IV induction of Crohn's. The other thing you'll notice that's built into this study, which I think is unique, is a head-to-head guselkumab, and the green bar on the right-hand side is with ustekinumab. So built into the study is not just placebo, but really looking at a head-to-head with ustekinumab. So this is Galaxy 2 and 3 now looking at the maintenance in Crohn's disease. And again, the reason there's the light pink and the dark is that's the two different doses for maintenance of 100 milligrams every 8 weeks or 200 milligrams every 4 weeks. And there's not placebo on this. This is the green bar is ustekinumab. And at the end, I'll ask you to comment, Anita, but we are seeing statistical benefit and efficacy of guselkumab, not just over placebo, but IL-12/23 ustekinumab. Now we, like Astro, sub-Q for ulcerative colitis, Gravity, sub-Q induction for Crohn's disease. And a very similar theme to what we just talked about in ulcerative colitis, the sub-Q induction, we did see statistically efficacy for clinical remission and endoscopic response, independent of bio-naive, which are the middle sets of bars, or bio-IR, so patients who had been on a biologic therapy, and seeing these nice deltas. Similarly, if you use subcutaneous induction in the Gravity and then you carry it out to week 48, you are seeing fairly large separation. If you look at the placebo responses here, very low, but quite a delta compared to guselkumab. So the sub-Q for Crohn's disease induction, as we talked about for ulcerative colitis, we're seeing benefit and efficacy with that. VIVID-1, now we're looking at the mirikizumab induction in Crohn's disease. You can see the blue is mirikizumab, the gray is placebo. This is the week 12 data, and you can see clinical response by PRO, endoscopic remission, and clinical remission. Again, statistical endpoints were met. These are the maintenance data with mirikizumab in Crohn's disease. Also at week 52, the endpoints were met. Now, in one of the studies, VIVID-1, one of the secondary endpoints was comparing mirikizumab to ustekinumab. Ustekinumab here is in green. And I think you can see something different than what we saw with guselkumab in that we're not seeing a statistically higher benefit or efficacy of mirikizumab versus ustekinumab. The bars look very similar. Some of that has to do with the methodology, the way the study was designed, but we did see a separation with guselkumab and ustekinumab. We're not seeing that with mirikizumab and ustekinumab. So now risankizumab induction in Crohn's, Advance and Motivate. It's just the patient population in Advance was a mixed population, meaning some were bio-naive, some were bio-failure. Motivate on the right-hand side is all bio-failure. And again, you're seeing statistically higher rates with risankizumab compared to placebo. This is looking at side-by-side clinical remission and endoscopic response with the theme and the message that we're seeing good not only clinical remission, but also endoscopic response with risankizumab in Crohn's disease. And then finally, risankizumab did have a comparator trial sequence with ustekinumab. And as I mentioned with guselkumab, although this trial was designed a bit differently, and Galaxy did build in an arm of ustekinumab, but nonetheless, risankizumab compared to ustekinumab, you do see a separation and an efficacy benefit with risankizumab compared to ustekinumab. So before we get to the cases, and this will be the remainder of our next hour to hour and a half, I want to ask you, Anita, in terms of the Galaxy study, and I know you were involved in that, kind of maybe high-level comments. We talked about the built-in arm with ustekinumab. Any observations you want to share?
Yeah, so with the Galaxy study, we were able to have a treat-through design, which in other words says no matter what the medication the patient was started on at the start of the study, they continued on with that. And so that really allows more of that real world, if we could use that this is the real world, actual clinical practice of what happens when a patient gets started on guselkumab or ustekinumab or is on placebo, right? So that was very telling for us. Also, the doses, as you highlighted, Miguel, overall, you could see that they both doses, 100 milligrams or the 200 milligrams, we were able to see efficacy at, again, high percentages that typically we have not seen previously. Having that active comparator with ustekinumab was very informative. Sequence, as you alluded to, was designed differently, but incorporating ustekinumab into the Galaxy allowed us to do several post hoc analyses, of which we've presented at many of the major congresses, and it's manuscript in process, so that's coming here at a theater near you. So it'll allow you to be able to, it allowed us to perform an analysis, Miguel, where we said, what about the patient who initially received ustekinumab and then lost a response or didn't have a response? Now can we perform our analyses of when we switched them to gazilkumab, what happens? And what we actually found was once we switched them to gazilkumab, and this was without an IV induction, we went straight to the sub-Q. We switched them to 200 milligrams sub-Q of gazilkumab, previously been exposed to ustekinumab. And we found that the efficacy, durability, rapidity, all of those endpoints were comparable to as if a patient was in that cohort of bio-exposed and then received gazilkumab. So that's very telling for us, an answer that Sequence was unable to give us.
Yeah, and I think, so really important data that I didn't present, that I think you presented at the European, one of the European meetings, is that the question comes up if a patient's been on ustekinumab and failed or lost response, can use an IL-23, and we do have efficacy data with gazilkumab that I didn't present. Angelina, let me ask you a question about the sub-Q induction with Crohn's, kind of similar to ulcerative colitis. Maybe the answer is going to be identical. Are you using IV gazilkumab in Crohn's induction, or you've really switched over to sub-Q? What is that looking like in your practice?
Honestly, this has to do a bit with patient preference and what is going to be easiest for the patient to do. I've been surprised. I thought everyone's going to want sub-Q. Like, why would you want to go into an infusion center for IV? But in fact, I've had some patients that have really said, I'm used to that. They're used to being monitored and having an IV. But I will say the majority of my patients are now I'm going with sub-Q induction. It really is shortening the time to medication when you can use the sub-Q induction compared to IV, so you're not just waiting for insurance authorization and then, to Ed's point, like finding a chair and getting your patient scheduled. The sub-Q does really get the drug to patient faster.
Yeah, I agree. I mean, I think most of my patients, you're right, there might be a rare exception. Yeah. Most of my patients were using sub-Q induction with gazilkumab for both Crohn's and ulcerative colitis. There might be a rare exception. Ed, there was a question that came in, and then we'll start with the cases. The higher doses of IL-23, are they related to side effects? So the question was specifically, I showed the doses of gazilkumab that were done, and the 200 milligram had the higher efficacy, but there were even higher doses that didn't show any benefit. But for risankizumab and gazilkumab in maintenance, we do have two doses, a lower and a higher. Higher, maybe we get some efficacy benefit, but then is that a trade-off, or are we seeing safety problems with the higher doses?
Yeah, that's a great question. I would say, contrary to what we see in some other mechanisms of action, we don't see that. Yeah. And just to be very clear about what I'm talking about, when we see induction doses with JAK inhibitors, for instance, I think we tend to see more shingles risk, more infectious risk when we have the high dose compared to like when we go down to the lower dose for maintenance. We don't see that with the higher dose of IL-23 that I'm aware of. Any of the panelists, know that data better than me. Definitely correct me, but I don't think we've seen that with IL-23s.
Yeah, so I think one of the nice things, and just a take-home point, sometimes people say, well, I don't want to use the higher dose of risankizumab or gazilkumab in maintenance because I'm worried. We talked about the liver or some other potential side effects. We are not seeing a safety trade-off. So the nice thing with this is we're not seeing a safety ceiling, meaning higher doses don't equate to worse safety. So generally in my practice, and I realize I have a referral bias at Cleveland Clinic where I might have a sicker patient, I am using the higher doses in maintenance for both gazilkumab, 200 every 4 weeks, and for risankizumab, the 360 every 8 weeks. The data on the lower doses in maintenance for both of those look quite good. So I don't want the take-home to be you have to use the higher dose, but we are not seeing a safety trade-off with that. All right, so let's dive into our patients. First of all, get ready because as an audience, I'm going to present the case, and then we're going to ask you all first what you would do in terms of the multiple choice options for therapy. So this is a real patient. Some of you may have seen Natalie at some of our meetings. She's also a patient advocate. She's 42, long-standing Crohn's ileitis. She's had this since 21. She now has worsening symptoms that you can see there. She's actually been in a long-term remission with adalimumab, and there was a payer-mandated switch to adalimumab biosimilar. And she felt not only that she was frustrated, but she felt that she also started to get more symptoms. One very quick editorial comment: we've not seen a difference in terms of efficacy in biosimilars compared to the innovator product, and I want to make it very clear, I am personally comfortable with the biosimilars. However, we do have patients like Natalie who tell us, and it might be more than even the nocebo, and then we can get into whether we check levels. Nonetheless, she started to have more symptoms, and now she's saying, okay, I've been on adalimumab every 2 weeks and doesn't want to be on an IV therapy. And oh, by the way, in the very bottom right of this is something that you may see in your patients in TNF. She's noticing that she's starting, it's not terrible, but she's starting to get the psoriaform reaction and the umbilicus around the ears and the scalp. I tell my fellows, if you examine patients on TNF inhibitors, patients will say, I have a little drynness in my belly button. That's probably actually a psoriaform reaction in TNF. Usually it's very mild, you don't have to do anything about it, but she's starting to get it in her scalp and her ears. You can see that based on objective data, CRP, fecal calprotectin, she has elevation. Importantly is the third bullet point. An adalimumab trough level was measured. It was 19, which would represent what I would consider an optimal trough level, and she has no antibodies. And you can see her hemoglobin platelets. Her albumin is 3.5. It's on the low end of normal, but it's not abnormal. All right, so here is where all of you come in. What would you do next? If you saw her, adalimumab every 2 weeks, now she's flaring, good levels, high inflammatory markers, would you increase her to once a week? Would you switch to another TNF? Would you switch to an IL-23, vedolizumab, upadacitinib, or would you give her another course of budesonide and simply say, let's wait a little bit longer and see how you do? So please go ahead and answer this. We'll show the bar. By the way, on many of these questions, by the way, there's not a single right answer. We might have some preferences on the panel or from the others that you hear, but go ahead and answer that. And then whoever in the back is controlling this, when the time's up, pull up the bar graph and we'll have a discussion. Apropos. We feel with our headsets on that I feel a little bit like Mission Impossible. All right. So we have a small percentage increase to weekly adalimumab, another that says switch to another TNF. The large majority, 87.1%, said switch to an IL-23. Some said go ahead and switch to Vedo. Some said switch to upadacitinib. And some said give her a little bit of budesonide and see how she does. Before I get to the community gastroenterologists and how they answered, Ed, anything surprising here or any comments you would want to make?
Yeah, so I think it's a little bit interesting that we have a smattering, we have at least one answer to each one, and I think that's really shows you what you said. There's maybe not one right answer, so people can think about this in a little bit different way. I think when I think through this case and sort of how this case is progressing, I think the psoriaform rash is the thing that stands out to me the most. The disease activity we could probably tackle in a couple of different ways, but in my experience, when you have a psoriaform rash, especially to the anti-TNF, that is not likely to respond to another anti-TNF. In fact, the anti-TNF will probably drive that same reaction again. And knowing now that we have so many different mechanisms of action that we could use, as seen by this screen, and IL-23 works really, really well in this situation, and IL-12/23 also works really well in this situation, but we talked about some of that head-to-head data. So I think an IL-23 would probably be my go-to initial decision, in this particular situation.
Angelina, let me ask it a little bit differently. Are any of these choices one that you would not do, where you would look at it and say, that's not a great idea?
Yeah, that's a good way of looking at it too, because I call that the back door. Like instead of sometimes when you're like, there's multiple good answers, but like what is not an awesome answer. I think of a 19, trough level of adalimumab 19 as being within the therapeutic range. So that's not, I don't think going to weekly is going to benefit the patient in the sense of symptom control, and also because of the psoriasiform rash, I agree completely on that. That once you start seeing that, it's likely to worsen over time, maybe starting off mild, but once really, if you've seen this before, to Miguel's point, it's one thing if it's in a belly button, which is hideable, which you don't have to show that. Once you start getting it in the ears and then around the scalp, if you've ever seen severe cases of this, it is debilitating. I have had people, when you start getting it in the scalp, people will start losing their hair. It can be really awful, and almost to the point where people are really not wanting to even leave the house. So I do take the psoriasiform rashes pretty seriously. The topicals are okay if you're dabbling in it, but it can become really messy really fast. So long story short, I really would think about that, between the anti-TNF would not be the selection I would do because the trough is good. Switching to another anti-TNF agent, as Ed already mentioned, it is likely to continue this issue as we go on. So those were the easy throwouts for me.
Yeah, so I think the take home is if you dabble in it and it helps the mild psoriasis, that's okay. I like the dabbling comment. But we do worry about the scalp. Anita, question is, she's a newscaster. Now I'm going to ask you which of the three IL-23. She's a newscaster. You kind of heard some of her preferences up front. Maybe this is self-evident, but which of the three would you lean toward?
Again, the convenience factor, right? And so with that, being able to have these sub-Q formulations seems to be the most palatable probably for her, as well as with that easy button we talked about, right?
Yeah, and I think also, obviously, she is cognizant of, she is a public figure. She doesn't want to go in an IV infusion, so there's that as well. All right, so let's go forward. This is going to be cool because now you're going to hear, if you can play the audio, you can read the screen, but let's hear what a community gastroenterologist said about Natalie.
The patient has been on adalimumab or its biosimilar for some time, but has had a flare requiring steroid rescue. Her disease level is at least moderate, including constitutional symptoms of anemia. She has elevated biomarkers. I feel it is time to change to a different class of advanced therapy, and an IL-23 has unsurpassed efficacy, a better safety profile than upadacitinib, and should be efficacious in psoriasis should she prove to have that. Vedolizumab would likely be less efficacious, but an acceptable choice if she has any relevant conditions that would make a more gut-specific agent preferable. A subcutaneous route of administration would be preferable given her social circumstances.
All right, so we laughed at some of the pronunciations. This actually is a community gastroenterologist, but the way the audio dubbing is sounds very mechanical, so bear with us as we go through that. But these are real responses, yeah, the AI world we live in. All right, so how about a rural gastroenterologist? Go ahead and play the audio.
I would increase dosing frequency of her current adalimumab therapy. She was in long-term remission on adalimumab. She's only been symptomatic for 6 to 8 weeks, and the only major change was a payer-mandated biosimilar switch 3 months ago. Before I start chasing newer agents, I want to try the most practical, familiar, and insurance-friendly step first. If this is pharmacokinetic loss of response after the switch, dose escalation is a reasonable move and often easier to get approved than a full therapy change. I'm also not ready to assume she needs a whole new mechanism yet. I would check trough antibody levels, rule out C. diff, and recheck C-reactive protein and fecal calprotectin. I would not switch to another anti-TNF agent. I might consider this if she has antibodies or true secondary loss of response, but switching within class is still a big move. Also, insurance may make it painful. I would not switch to an IL-23 inhibitor. I know the data look good, but I'm still cautious with newer therapies. I want more real-world durability and long-term safety experience before making that my go-to, especially when she did well for years on anti-TNF. It may be fine, but I don't want to be the first one in my zip code to find out it's not. I would not switch to vedolizumab. It's safe, but it's an infusion, and she specifically wants to avoid IV therapy. Also, it may take longer to kick in, and she's already flaring. I would not switch to upadacitinib. It is effective, but it's a systemic JAK inhibitor. I'm not reaching for that unless I really have to. More monitoring, more safety baggage, and it's not my first move in someone who was stable for years. I would not use budesonide. She's already needed steroids and is still symptomatic. That's how patients slowly drift into chronic steroid dependence while the disease keeps simmering.
All right, so it's interesting. Some of you in the audience did say you would go to adalimumab weekly. So this is where you are hearing variations. Let's hear from the community, and then I'll show you some other responses.
I would switch to an IL-23 inhibitor. She had long-term remission on adalimumab, then had a payer-mandated biosimilar switch, and within 3 months, she's flaring again and already needed budesonide rescue. That's a signal this isn't just a bad week, this is loss of control. What really pushes me towards switching mechanisms is the new and worsening psoriform rash, umbilicus, ears, and scalp. That's consistent with paradoxical psoriasis from anti-TNF exposure, and I'm not going to fix that by doubling down on the same class. I would pick guselkumab because it offers subcutaneous dosing, and she wants to avoid IVs and time away from work, and it supports durable steroid-free control. Why I'm not choosing the other options. Increased dosing frequency of her current adalimumab therapy. This could work if this were purely low drug exposure, but the rash makes me think she's developing a class-related problem. I'm not optimizing a drug that's also causing a new inflammatory skin issue. Switching to another anti-TNF agent. If she had antibodies or injection issues, maybe. But paradoxical psoriasis often follows the class. I'd rather pivot mechanisms than keep rolling the anti-TNF dice. Switch to vedolizumab. This is effective and safe, but it's IV-based, and she's trying to avoid infusions. Also, it won't help the rash. Switch to upadacitinib. Strong efficacy and oral convenience. But I typically use this after biologic failure or when I need speed. Here, IL-23 gives me durability and skin benefit with a cleaner long-term comfort level. Manage symptoms with budesonide and reevaluate in 3 months. No, that's how steroid dependence starts. She's already showing she needs escalation.
All right, so you're hearing some themes. I'm not going to play these, but a few other people said they would switch to IL-23. There was somebody, because she had been on TNF, upadacitinib. And I think we're hearing themes of, as what we're saying, would probably be things we wouldn't do. So certainly budesonide, I think everybody agrees. Let's hear from Millie Long what she said.
Hi, my name is Millie Long. I'm a professor of medicine and chief of the Division of Gastroenterology at University of North Carolina at Chapel Hill. And here I specialize in the management of inflammatory bowel disease. So to start things off, I'd like to discuss case number 1, Natalie. So my answer for what to do in Natalie's care is actually option C, switch to an IL-23 inhibitor. And let me tell you why. So Natalie has Crohn's disease. She's 42 years old. She has been on adalimumab. And importantly, she has had a recent level checked, which was therapeutic. It's at 19. And also in her clinical history, she actually has started to report a mild psoriasiform rash. And this is kind of around her umbilicus and behind her ears. And so what this is most likely an anti-TNF induced kind of psoriasiform eruption. So interestingly, you can see some of these paradoxical reactions on anti-TNF. And recently in the literature, it's actually been shown that an IL-23 receptor abnormality, a genetic abnormality, is actually associated with this. And so the IL-23s are the best agent to manage this psoriasiform eruption. Importantly, it also is an agent that has shown great efficacy in Crohn's disease in individuals who've previously been exposed to an anti-TNF. And she not only has been exposed, but she has had, a mechanistic failure of that anti-TNF. A couple of other pearls. Remember that we never go on symptoms alone, and she did have objective workup of her symptoms where she had an elevated fecal calprotectin, and importantly, a colonoscopy with an SES-CD of 11, really markedly involving the ileum, and that's a very high SES-CD if someone has isolated ileal disease. So she actually has quite severe disease. We need to get our best foot forward.
So one thing we wanted to show you is this, and actually this came out, wasn't something we kind of, when we were planning this program, necessarily brought up, but Angelina, you mentioned Ed, Anita, and you're hearing from Millie, this paradoxical reaction. I'm not going to go through this in detail, except to say it is something we see in TNF. It is something that will worsen if you continue, increase, or switch within class So this is really something, and Millie mentioned the very last bullet point on this slide, which I think is interesting, that this may actually be one of our predictive markers, the IL-23 receptor gene. It's not something we can necessarily measure in clinical practice yet, but usually these patients do quite well with IL-23. We're going to hear now from Jessica Allegretti and then Ed Loftus, and then we'll move forward.
Hi, everyone. My name is Jessica Allegretti, and I'm the medical director of the Crohn's and Colitis Center at the Brigham and Women's Hospital in Boston. And for case number 1, I would choose C, switch to an IL-23 inhibitor. And that's for several reasons. Here we have a young woman who has experienced secondary loss of response to an anti-TNF. We know she has a good drug level. She has not developed antibodies to the drug. So really we want to move out of class to a new mechanism of action. We also note that she has a preference towards sub-Q injections over IV infusions. And we know that there are agents within the IL-23 class which are entirely sub-Q or even mainly sub-Q with an IV load. So I think there's a lot of flexibility there. We also note that this patient has a psoriaform rash, and we know that IL-23 inhibitors also concurrently treat psoriasis and are approved for that indication as well. So I think overall, that's going to be a great choice for this patient.
Great. So Anita, you mentioned the sub-Q easy button, which Jessica's mentioned in as well. And then finally, Ed Loftus.
Hello, I'm Ed Loftus. I'm a professor of medicine at Mayo Clinic in Rochester, Minnesota, and I am not a Pittsburgh Steelers fan.
I'm a Pittsburgh Steelers fan.
Regarding the first case, this is a case of somebody who, switched to an adalimumab biosimilar. Their symptoms have been worsening. They're getting a little bit of a psoriasiform reaction. They have a therapeutic trough level, no antibodies. We have objective evidence of inflammation as manifested by the fecal cal and the colonoscopy. So this patient does need to switch therapies. I probably would not go with an anti-TNF because the psoriasiform reaction that'll happen with the next one. I do like the option of an IL-23 inhibitor here. I think IL-23 inhibitors work particularly well in this sort of anti-TNF failure setting. And for this particular patient, because she's expressed a desire for subcutaneous therapy, I'd probably be leaning towards guselkumab. I suppose you could also consider the other two anti-interleukin 23 inhibitors, although the initial doses would be IV, although that would be a limited period of time. So for all those reasons, I'd be probably picking an anti-interleukin here.
Right. I'm actually going to ask you not to play the audio on this, so don't hit the audio. We did put this through ChatGPT, and kind of just in the effort of time, since you heard already the digital voices, it chose IL-23. I will tell you that the next case has much more variability. I think this one was a kind of an easy starter case. But let's hear from Natalie kind of directly, her thoughts.
My name is Natalie Hayden. I'm 42 years old. I was diagnosed with Crohn's disease at age 21. I have 3 kids, ages 8, 6, and 4. I'm a former TV news anchor and reporter, and I blog at lightscameracrohns.com. My senior year of college, I went on spring break to the Bahamas, and I'll never forget the abdominal pain that I felt. And in the moment, it was the first time I ever dealt with something like this. Fast forward to May, when I graduated from Marquette, my symptoms really started to persist. I'm talking about fevers of up to 104 on multiple occasions, and then horrible chills. So I went into this not even knowing what was wrong with me. And they did a rectal exam, and they did a CT of my abdomen. And I kind of blacked out in the moment, honestly, because I don't know how I reacted when the doctor walked in the room and he said, "You have Crohn's disease, you are malnourished, you're dehydrated, you're getting hospitalized immediately, and you're doing a colonoscopy in the morning to confirm this." And my world came crashing down. I went from being a perfectly healthy, self-sufficient, driven, ambitious 21-year-old who had the world by the tail, who planned to work in TV news and take it by storm, to somebody who was hospitalized for a week, having to do a colonoscopy.
And then in terms of her quality of life,
So when you have IBD, you don't know what the next hour brings. You don't know what the next day brings. Yes, you might be in remission today, but what about tomorrow? And I think that's something so many patients and caregivers struggle with, is the unpredictability and is such a challenge with this disease. We can think we have it under control. We can think the treatment and therapy is working. We can say the scope looks clean. We can say the labs look like they're on target. But then all of a sudden, something could happen the next day. So that's been a struggle even 20 years in.
so I think, it's important to hear the patient voice in this, and we really appreciate Natalie being vulnerable to share her story, and I think this also puts in perspective some of how we need to interact with patients. Now, just coming to the end of this case 1, before we get to case 2, this is kind of the table scorecard of what was discussed, and I think the majority of people, and then AI, also picked IL-23, but a couple said increase the adalimumab. Somebody said upadacitinib, which, by the way, I don't know was necessarily been wrong. It's just the IL-23 in terms of some of the safety, the efficacy would probably been what I would have gone with as well. And I think some pearls from this case, and then we're going to ask all of you again if you changed your mind or changed your decision one way or the other. But we talked about the psoriaform reaction. We talked about some of the ACG actually put this in their guidelines in terms of prior intolerance to therapies, safety profile, life stage considerations, and then this idea of a loss of control after a biosimilar to switching to a biosimilar, which in Natalie's case did come up. All right, so we're going to ask you the same question. You may have the same answers before, or you may have changed your minds. What would you do in Natalie's case? Increase the adalimumab, switch to a different TNF, IL-23 inhibitor, veto, upadacitinib, or budesonide. So take a second to respond to that, then we'll reflect on this again. As you do that, one comment I'll make, and Anita, I'm curious. Some of our patients, you mentioned how devastated Natalie was over her Crohn's. I've had some patients even equate this to as if they got a diagnosis of cancer, which we always think is the truly worst diagnosis, but in terms of a lifelong condition, that's something that we've seen as well.
Yeah, it's definitely hard for them to hear for the first time with that diagnosis.
All right, and I'll let you react to this. So it looks like, actually, did really 100%. It looks like everybody switched to IL-23. Any final comments?
If I could make a comment, I really appreciated everyone's reasoning behind why they would or would not make a treatment selection of one or the other. The one that impressed me the most was, I believe it was one of our community gastro, the rural gastro community individual who said that they didn't want to be the first in the zip code to prescribe something. I'm really concerned about that, particularly practicing in a tertiary IBD center, and we're always emphasizing the importance of finding the right patient with the right treatment at the right time. And time is of an essence. And so oftentimes these patients are in different parts of the country, rural America, wherever it might be, the suburb, whatever it might be. And then to see or hear that kind of reasoning, that makes me a little concerned. So that was the one comment from all the reasoning that I just really wanted us to pause on a little bit and say, is that really, as healthcare professionals, how we should be practicing?
Well, one thing that will come out in the second case, not to give it away too much, is we see that stark contrast as well, where newer therapy, IL-23 in this case, raises a pause and concern over safety. I think, Anita, to your point, now with ACG guidelines, AGA guidelines, now long-term extension data with safety, I think the message that I want to make sure we get across, and I think, Anita, you're echoing that, is that this is really one of the safest classes of medicines we have in an IL-23, and we shouldn't limit its use, even though it's newer. And I understand that concept, but we do have enough data, especially also with psoriasis and some of the rheumatologic indications over time. All right, so let's move to the next case. I may ask the back of the room for some of the audio on these. I'm going to probably read the slide, then hear the audio, just because I want to make sure we have enough time for a discussion over the Q&A. Okay, so this is our next patient advocate, a 34-year-old. Now, this is with ulcerative colitis. She's had symptoms for the last 3 to 4 months, and you can read through those there. This is impacting her quality of life. She's been on multiple courses of prednisone, and she's worried about long-term effects. And I'm glad to hear that, at least in the first case, the concern about budesonide as a bridge to chronic steroids. Certainly she's worried about this as well. She's been on a 5-ASA, both oral and rectal, and she's been on infliximab in the past, and she is feeling discouraged that she's not getting better. Very key important point, bottom right of the slide, is that she is really wanting to start family planning and start trying to get pregnant within the next year. This is a very strong interest that she has, and she did bring that out in her visit. So the endoscopy shows that she does have ulcerative colitis. The Mayo endoscopy score is 2, so she has moderate colitis. She's not toxic. She doesn't need to be admitted. CRP is high. Fecal calpro is high. You can see she's a bit anemic, and albumin of 3.5. So for all of you, she's been on infliximab, multiple steroids. What would you do next? Would you just stay the course and try another dose of steroids? Would you switch to another anti-TNF, switch to an IL-23, switch to upadacitinib, switch to Vito, or begin thiopurine monotherapy? So kind of take a minute on this. And for the panelists, we are going to talk about pregnancy during this as well, and kind of that implication. So take a second. Let's see what people say.
This music's better.
Ed, you approve of the music?
Yeah.
Gonna get you to start dancing for us.
Yeah, the intro. I tried to get my son to have this as a walk-up song.
All right, good. And I think, again, I want to state, we don't want to sit up here and say there's one absolutely 100% correct answer. I think there's some that are probably more correct than others. Most would use an IL-23, but some said upadacitinib, some said vedolizumab. Maybe Angelina, she said she's interested in getting pregnant in the near term. Is upadacitinib contraindicated in any woman who's interested in getting pregnant, or what's the implications of upadacitinib in pregnancy?
I'm glad you asked it in that way, because I don't think every woman, just because they're within an age that they could get pregnant, means that you have to throw out the entire JAK class, right? I just think that when the situation's warranted, when it's the right, to Anita's point, actually, you said it really well, right patient at the right time in the right scenario, you pick the medication that's going to be most effective for the patient. In this situation, however, or in general, I usually don't necessarily want someone who is who's thinking about pregnancy like imminently or actively trying to be pregnant. It's not my preference to have someone on UPA. That's in my practice. There are certain scenarios, I know there's been a lot of talk about this in like certain scenarios, patients that are really that have no other options and what you're going to do. That's not what we're talking about here, because she really has only previously been on infliximab, and she stopped that because of intolerance, right? I'm curious about those infusion reactions, but that's another topic for another day. So she has a lot of good options that are safe in pregnancy. All the biologic agents have really been found to be safe in pregnancy. There's a lot of data surrounding safety in pregnancy and with breastfeeding as well. And remember, we really want our patients to breastfeed, right? We know that there may be a reduced risk of heritability of IBD in a baby born to a mom who has ulcerative colitis or Crohn's disease if you breastfeed. So like there's another rationale for just like carrying the medication through, not just pregnancy, but also in the postpartum period as well. So for me, I would prefer to use another agent than UPA in someone who is thinking about pregnancy in the short, long term. Yeah. But the only caveat too, I know this is a long answer, but making sure she's in remission before she tries to conceive is also a super important aspect. So it is really important to understand our patients' goals. I think this is critically important for us as their provider to understand what their goals are. And getting to a healthy pregnancy is good, but we want them to conceive when they're in remission. And I would usually love for people to be in remission for 6 months if we could, 3 months if you are, negotiating, or if time's of essence. But that's usually what I would want to do.
Yeah, so I think the message is that upadacitinib is not contraindicated in a woman who wants to get pregnant in the future. But as Angelina said, if she says, look, this is something I want to try to get pregnant in the next 6 months to a year, if you did start upadacitinib, you would have to then stop it for a month prior to conception, how long it takes her to conceive a pregnancy then, and then switch to something else. So I think that's an impact. Ed, just briefly on vedolizumab. What's your thought about vedolizumab after infliximab and ulcerative colitis?
Well, I think that, the downside of using vedolizumab after a patient's been on an anti-TNF and ulcerative colitis compared to vedolizumab first line is you do see that drop off in the efficacy. And I think in somebody that's presenting like her, she's not, as you said, she's not about to be hospitalized, but she certainly is ill. And I think given the scenario where we have other therapy choices, just like Angelina said, I think it probably wouldn't be my first choice. And I think just to echo one other point about the pregnancy, because her goal is to get pregnant within the next year, you want something that's going to give her the best chance of getting into remission. And so even if my choice was upadacitinib versus vedolizumab or upadacitinib versus any of these other things, I would choose upadacitinib to get her into remission and then give her another therapy rather than choose one that I thought might be less effective, at least based on the evidence that we have.
Yeah. So even with that, though, let's hear the audio for community gastroenterologists who said switch to Vedo. So for those out there, you're going to hear a couple of similar answers. So go ahead and play this audio.
The patient has at least moderate UC with several flares that have required repeated steroid rescues. She has had intolerance to a TNF, so best to avoid others. Using further steroid therapy is ultimately ineffective and dangerous long-term. An IL-23 would be acceptable. Upadacitinib is very effective, but her prospect of pregnancy makes me inclined to use a relatively gut-specific therapy, vedolizumab in this case.
Great. Do not play the audio for this, but I'm going to kind of go through this briefly. I want to point out this is another community gastroenterologist, 9 years of experience, who also said switch to Vedo. Look at the final bullet points on the left-hand column. And this is something I think Anita kind of brought out before, kind of this limited familiarity with IL-23 data in pregnancy. And that was really, I think, the driving reason this person said they wouldn't use IL-23. They would favor vedolizumab. Similarly, there's another community gastroenterologist who also, actually, I think that one's the same. There's a rural gastroenterologist who picked vedolizumab and also had the question about safety of other therapies. And I think this is something that it's interesting to me, you're seeing in a fair balanced way in the real world. And I think about a third of you had said vedolizumab was an option. And then some additional commentary that we got from others are switched to IL-23, two said Vedo. But let's get to, what did Millie say?
For case 2, Kayla, she has underlying ulcerative colitis. My option for what I would do in terms of her management would actually be option C, although with a caveat that we also need to consider option D. So, when you think about Kayla, she's quite symptomatic with stools that are frequent, with blood and urgency, and she's actually required a good number of prednisone tapers over the last year. And one teaching point, someone should never have recurrent prednisone tapers without a change in therapy. When you're initiating steroids, you need to think about what your exit strategy is going to be in terms of maintenance, whether that is a biologic, a small molecule, some form of an advanced therapy. So importantly for Kayla, she had previously received infliximab, but had intolerance to that. Not very specific intolerance, but more headache, infusion, possible reaction. But I always would want to dig in deeper to that because it's a little bit different if the patient just didn't feel quite well as compared to actually having an anaphylactic episode where they had shortness of breath, severe rash, blood pressure drop, et cetera. So you want to dig into that and learn more information. And importantly, she also had an objective evaluation of her symptoms, meaning she had a fecal calprotectin that was elevated, and she had an endoscopy, a flexible sigmoidoscopy that showed Mayo 2 disease, moderate disease. And so in this setting, we really need to initiate her on an advanced therapy. She'd previously had that infliximab exposure, which is why it opens up options in another class. And so an IL-23 is reasonable here, particularly if she's 34 and is potentially interested in planning a family. When we think about planning a family, all of our biologic agents are safe, but we do want to try to avoid an advanced therapy like a JAK inhibitor if possible.
And then how about Jessica? And then you'll hear the pregnancy, and then I'll ask a question to the panel. Go ahead and play the tape.
For case number 2, we have a young woman who has moderate disease, clearly failing 5-ASA therapy, has had a previous experience with an anti-TNF that did not go well, and very clearly needs to be on an advanced therapy. I think when I'm thinking about this patient, the things I'm taking into consideration are speed, the safety profile, and additionally, this patient wants to start a family soon. So certainly that's going to play a role when we're considering what therapy to start. We know that the JAK inhibitors are currently contraindicated in pregnancy, and if this is a patient who's wanting to start, trying to conceive soon, I would not use upadacitinib. And we know that from the piano registry with Uma Mahadevan. So for me, I would choose C, switch to an IL-23 inhibitor in this patient. We know that's going to be safe. Once we get her into remission, she can safely start trying to conceive, and she's going to have some real durability with this agent.
All right. We also we have some data from the piano study, and I'll show actually the next slide's a great table. I'm going to call an audible and just ask for a raise of hands. I promise I will not pick on anybody if you raise your hand. How many out there do have questions or concerns about IL-23 in pregnancy? I'm curious, and don't be shy. So I do see a few hands out there. This is something that helps us from an educational standpoint, because I think we get used to seeing patients in a tertiary center, and you heard from Anita initially. We don't have concerns about IL-23 in pregnancy, but that clearly was a theme that came up with a couple of the other comments in the community and rural gastroenterologists. The piano registry, I think we've kind of outlined this already. This is a table that I'll leave up for a second. This is hot off the press, very recent, clinical gastro and hep, the IBD medications from preconception through pregnancy and lactation. And you can see preconception on the left, all the way to lactation with the different trimesters. And I think the bottom line take home, and I think everybody, if I asked, is methotrexate contraindicating pregnancy, would say yes and raise their hand. I think we all know that. At the very bottom of this slide, the oral small molecules, JAK inhibitors, we haven't talked about the S1Ps, but the S1Ps, ozanimod, etrasimod, are also not used in pregnancy. But all of the other therapies, the monoclonal antibodies, even thiopurine, aminosalicylates, but all the monoclonal antibodies are safe. We don't stop them in preconception. We don't stop them in any trimester of pregnancy. We don't try to hold the last dose at the end of pregnancy. So I think for Kayla, and this was educational for me, this concern or question about IL-23, because it's relatively new and the feeling is we have data. This is actually published, and I think this table is a guide, is very, very helpful. Let's finally hear from Ed Loftus.
So for case 2, this is somebody with active UC. They're requiring frequent steroid tapers. They've already failed infliximab. They didn't tolerate it very well. Importantly, they're interested in starting a family in the near future. They have objective evidence of the Mayo endoscopic score is 2, so there's moderate disease. And so I think you definitely want to get them on an advanced therapy. You have a lot of different options because they failed an anti-TNF. Maybe I wouldn't be, they didn't tolerate it. I wouldn't be too interested in that. I would probably be thinking of an IL-23 inhibitor, upadacitinib, although the fact that she's starting a family soon, I probably would not do upadacitinib. If she was saying, yeah, that's something theoretical years away, that would be different. So overall, I'd be leaning towards an anti-interleukin. I guess veto is an option, although in an anti-TNF failure patient, I'm a little less excited about that as an option, but it would still be a potential option.
It might be worthwhile to talk about a failure versus an intolerance, because I think this is this is something that I keep hearing, and
Yeah, so that I think you can look at it two ways. So what Angelina is referring to is we've had patients who've had an intolerance to infliximab, adalimumab, and it's kind of vague symptoms, headache, maybe a little bit of fatigue after the injection or the infusion. It's not a reaction because of an antibody development to the therapy. So I think that's a point well taken. We need to kind of keep that in mind. And I think about a third of you said veto, almost as if that would have been the first line therapy. Even though we're saying that, to be fair, patient who's been on infliximab says they have an intolerance. And in the third case, we'll get to bio-naive veto as some data on that that's relatively new, and maybe still using that in that bio-naive category. But I think, again, Angelina, and actually even ChatGPT agrees with you here.
So,
they're saying
yes.
they're saying vedolizumab's reasonable, but maybe go ahead and comment. What did you want to say?
I just think it's important here, always, like we talked about this in the APP track yesterday, thinking about documentation of medications. It's really important to understand when you start a medication, what were the symptoms when you started, and when you stop a medication, why. The difference between a primary non-responder, they never got better,
Right.
versus a secondary loss of response, they initially got better, but then couldn't sustain it, flared, versus an intolerance, which is, I didn't feel well, something happened. It wasn't anaphylaxis or an allergy, it's just an intolerance. Intolerance doesn't mean it was a mechanistic class act failure. It just means that it was an intolerance, and we don't quite understand why typically, right? We don't understand if it was it an active part of the drug? Was it an inactive part of the drug? Is it something else that actually was going on that just was a confounder? So to me, that is very, very, very important, and it's the difference between thinking, a lot of us would inherently think after an anti-TNF failure, we can't really go to veto. It might not work as well. That's what the data tells us, right? However, that's not necessarily how this got sorted out. And I really just wanted to take a moment about this as a talking point to think
So
through
would you be okay with veto? ChatGPT.
Would I? Yes, I would be okay with veto.
Anita and Ed, I want to ask you this specific question. So ChatGPT agrees with you. So that's, I don't know if that's good or bad.
Well,
in
if
a way.
ChatGPT agrees. No.
So I want to focus
that's
again
sure
on the
it's a good idea.
bottom left and the very bottom right. So ChatGPT, when we put this through, was focused on the safety and the experience with vedolizumab, and even to what we heard from some of the others in the community, raised this question about IL-23 and are there enough data in pregnancy? And when I asked for a show of hands, there were some of you out there were still wondering that. Anita, can we put this to rest? Are you comfortable with IL-23 in pregnancy?
Yes.
Very good. A woman, a few words. Ed?
Yeah, maybe I'll use a few more words. And I would say yes. And the graph that the table that you showed, just so everybody knows where that came from, that's from the global consensus guidelines on the management of pregnancy. And I was lucky enough to be involved in that. And what we did is I was one of the grade methodologists. So we looked at all the available evidence for all of these questions that we're asking about how to manage pregnant patients with IBD. And so, I'm biased because I was involved in it, but the point of telling you this is it really is a helpful document because it goes through every single question you could potentially have, in my opinion, about how to manage a pregnant patient with IBD or a patient who's contemplating pregnancy with IBD, and what is the evidence that would support how you would manage that patient during the course of that pregnancy. And if we don't have evidence for that, I think one of the really novel things that we did in this global consensus guidelines is because all of the experts that were involved in the room were from all over the world, we had these key concept statements that Uma and Millie and people came up with to say, how should we manage it in the absence of evidence? And so it's very clinically focused. And so if you haven't seen that document, I would definitely encourage you to say that. So that is a little bit longer answer than yes, but I do feel comfortable with the...
But yes is your answer.
Yes is the answer.
Comfortable with IL-23.
All of us agree
Again, the data from this in the table, which is in the publication, will be shared with you after this conference. So all of this is something that you'll have.
The best next step is option E, switching to vedolizumab.
We're not going to listen to you. But let's listen to Kayla.
My name is Kayla White. I am an inflammatory bowel disease patient, student, and IBD advocate. I was initially diagnosed in May of 2020. The pandemic definitely made my diagnosis a little bit harder. due to hospitals being chaos, specialists stopped refusing to take new patients, and overall being in that transition period between being a peds patient and an adult patient. I was 17 years old. I want to say at first I started noticing blood in my stool and frequency when I had to use the bathroom immediately after eating. From that, things kind of progressed just to more pain, joint swelling, skin irritations, fatigue, and I was a pretty textbook IBD patient, which definitely made my diagnosis a lot easier. I was diagnosed via colonoscopy and biopsies.
And then I think we have a little bit more.
I went to New York, and then immediately things just started getting worse from there. I was always so stubborn and really academically driven. So my mom was like, Kayla, you should come home. And I'm just like, give it another week, the medicines to start working, or I'll have a virtual appointment with my doctor so they can kind of see what's going on. I came home because I was missing class and it just wasn't sustainable anymore for me to be away from my family. And once I got off the plane, got home, slept because I got in that night and then went to the hospital the next morning. They checked my levels, my inflammation was off the charts. And my doctors told me that if I would have stayed in my dorm another day longer, I probably would have passed out. And due to me having a single dorm for academic accommodations, I don't think my friends would have noticed until a day or two that I wasn't coming to class anymore. So that kind of was what got me to a stopping point in 2021 where I was faced with, do I want to continue with medications or do I want to try and get surgery?
So again, I want to thank Kayla, as I did Natalie, for really participating in this program. There's a lot of vulnerability, but you also hear the resilience in our patients, which to me is incredibly inspiring. And I see this in my clinics and hear what these patients are going through. So thank you for our patient advocates. In terms of case 2, this is just a summary, and you do see a bit of a split. So 5 said IL-23. I think on the panel, I would be in the IL-23, so 3 of us said IL-23, but Angelina, I think veto because it wasn't necessarily a failure of infliximab, and I think we're hearing that as well. And I think some of the take-homes for this is all of us agree that steroids are not a long-term option, and that does mean that we should move to another therapy. And then this question about treatment intolerance versus failure, and then therapy selection. So let's ask all of you, then we'll end with the third case, and then I am definitely going to leave time because there are a lot of questions that are great, so I'm going to make sure we have time at the end. But what would you do? Any changes in how you would treat Kayla, continue current therapy, switch to another TNF, IL-23, UPA, veto, or begin thiopurine?
And just for clarification, if I may, I was saying that I didn't think veto was wrong because it wasn't truly a failure. Just to be clear, I think
So
that
you're changing your vote?
No, I'm not changing my vote. I'm saying you could either do an IL-23 or veto would be the best options. In my opinion, if you were asking my opinion about what would I actually do, I was picking on the fact that it wasn't a failure.
I'm giving you a hard time because the point is that veto is a good is a reasonable option. So,
and the point also is that ChatGPT is wrong.
Yeah, well.
Wait a second.
Don't say that too loud. We're probably the world of bots are going to take over.
Exactly.
Well, so it sounds like most of you actually now are favoring an IL-23 veto. We didn't talk about thiopurine. I'll tell you that thiopurines exclusively for me are used in combination with infliximab. So I think that probably now would be considered a wrong answer. UPA's okay, but if she's really trying to get pregnant or getting pregnant soon, I think that's something we consider, and then you heard the rest. All right, so let's end with the final case, and this also gives some interesting discussion points that you may see in your practices. A 28-year-old, now this is a brand new diagnosis of Crohn's disease, having symptoms, it's affecting his quality of life, he's lost some weight, he's been on budesonide, that's really been the primary treatment, and he's also worried about long-term steroids. He has never been on any other therapy, so this is a brand new diagnosis of Crohn's disease. He has inflammation in the ileum and then the cecum, and as you heard Millie Long say, an SCSCD of 12 means that this is certainly moderate to severely active, doesn't have any complications, but you can see from his inflammatory markers they're elevated. Also, his fecal calprotectin's pretty high and didn't get that much better with budesonide. He is anemic, and his albumin's right at the end of normal. So what would you do for him? Sorry, we're bouncing around. Here are the options. Would you first-line therapy, Crohn's ileocolitis, veto, IL-23, UPA, TNF inhibitor, 5-ASA, and thiopurine? So take a second to answer that, and then we'll kind of do the same thing and go through some of the data. What would people do at this point? So this is different than the other cases. He's never been on advanced therapy.
It's a good case.
Huh? Good case.
Yeah,
Would you use a 5-ASA?
of course.
If you influence the audience.
This one's fun though, because this one is very real world. Everybody sees
This is real world. And actually, not to make a generalization, we may see this case less than you, meaning that sometimes when a patient's referred to a tertiary center, they've already been seen, treated, and now they're coming in. So this is great. Actually, this is really good because nobody's putting one. I mean, even though TNF probably by percentage was a little bit higher than an IL-23, even UPA, veto. 5-ASA, by the way, maybe you actually had somebody vote because you said that. 5-ASA is a wrong answer. This is one time I can say that it is a wrong answer. The data with mesalamine in Crohn's disease, especially ileocolonic Crohn's, is not, there's no efficacy at all. So I would not use a 5-ASA in this class.
And I will add,
Yeah, I was going to ask your thoughts. So
sorry.
let's go down the panel. Yeah, go ahead.
Even in our updated Crohn's disease guidelines, we were very intentional with bringing home and taking home that message for us, not just for us as prescribers, but even for our payers to recognize, because certainly there are still some insurance companies that are still mandating a 5-ASA in Crohn's disease. So we've incorporated that in our Crohn's disease guidelines, the living guidelines through the ACG.
All right, so I'm going to go down to each of you, and Anita, I'll start with you. If we come back to the audience response, or we can just do this. Anita, which therapy? For just say the name of the therapy.
The name of the therapy?
Yep.
I would do guselkumab.
Okay, guselkumab. Angelina?
I would do guselkumab sub-Q induction.
Ed?
I do infliximab azathioprine combo.
Okay. So you're hearing kind of some differences, and I think the audience, it was a little bit higher TNF inhibitor than an IL-23. And again, actually, let me ask Anita, upadacitinib, what about that for first-line therapy? The label change, does that help you say that's okay to use?
It does help me say it's okay to use in the right patient, but this patient is not knocking fully on the hospital door. I mean, as far as how rapidity of onset and all the rest that I would want or need in this situation, I would still feel very comfortable with having an IL-23 specifically as a class, knowing both rapidity and efficacy is comparable, and the safety it's superior.
Yeah, the one comment I'll make, and you probably all saw this, I think it was in October, the FDA did change the label for upadacitinib. So patients who've been on not just the TNF, but systemic therapy. Now, it gets a little bit vague. What's systemic therapy and who are inappropriate to a TNF? What's inappropriate to a TNF? So there is a bit of vagueness in the language. Now, some people would say systemic therapy would include a steroid. So a steroid could be considered systemic. I'll just say that that's a little bit vague, but I agree with kind of what you said, Anita. So let's go to the community. We'll listen to this one, and then I might just read out the others.
He should be tried on an advanced therapy at this point, having failed conventional therapy and having at least moderately severe Crohn's. I would use an IL-23. Avoid further steroid use. And I believe that an IL-23 is most likely to affect clinical and deep remission, as opposed to conventional therapy, mesalamine, or vedolizumab. Upadacitinib would be a reasonable therapy in this situation, but guidelines suggest not using it as first-line therapy before an advanced systemic therapy is tried. I would use it second line if IL-23s do not deliver results.
So again, in fairness to the community gastroenterologists we interviewed, these are real community gastroenterologists, but this is not their voice, just to say that again. The next one, I'm not going to have you play the audio, but this is a TNF inhibitor. So again, you're kind of seeing a split, IL-23, TNF inhibitor, and you can see some of the rationalization there. So if you could advance to the next slide. For some reason, it's not letting me. And then another community gastroenterologist said an IL-23. And then if we get to the other, if you can go to the next slide, the other respondents kind of split. So what did Millie say? Millie, take it away. If you can play the next slide and go to Millie Long.
For case 3, Brandon. Brandon is quite symptomatic and he has right-sided inflammation. My choice for Brandon's management would be D, initiate an anti-TNF therapy, with a little bit of an asterisk in that I use combination therapy with athiopurin with an anti-TNF in the first 6 months to help to prevent immunogenicity. So I would check a TPMT and potentially initiate athiopurin with the TNF. And in fact, I would actually use specifically infliximab. I do think infliximab, in terms of the anti-TNF agents, is my go-to in terms of the highest efficacy. So that said, he is naive to other agents. And so I think this is someone who you could consider an IL-23 inhibitor. You certainly could consider vedolizumab. I don't choose vedolizumab as readily in someone with predominantly ileal disease. I just don't think it has as great efficacy. And a JAK inhibitor is something we could consider. Now, remember that JAK inhibitors, the initial label said that they should only be used after a TNF agent. But the updated label says that it can be used after other systemic therapy if it's inadvisable to use a TNF. At this point, I don't think it's quite inadvisable to use a TNF, so I might still reserve that. But remember that label change for future use of upadacitinib. Now, there is one answer here that is clearly wrong. All of our guidelines recommend against initiating mesalamine, so that should just not be done in ileocecal Crohn's disease. So that is truly the wrong answer. In reality, our data truly show that early initiation of advanced therapy improves outcomes. And I think that any of these agents could be utilized. I think you could have a shared decision-making discussion with the patient himself over what he could potentially be most effective with and adherent to. I do emphasize that he really has been using budesonide and other things. Remember that no one should have recurrent courses of steroids, whether that's budesonide or prednisone. We really need to be thinking about an exit strategy.
Great. And so Ed, by the way, is at University of North Carolina. Millie Long is the chief of the University of Carolina, and their answer was identical.
Exactly.
So infliximab and azathioprine. I'm just making that point.
I made it under my breath.
I want to have a job on Mondays.
Let's go to Jessica Algretti. None of us are with Jessica, so let's see what she said.
For case number 3, we have a young man who's newly diagnosed or recently diagnosed with ileoclonic Crohn's disease and clearly needs to be advanced to an advanced therapy. And so this will be the first advanced therapy that this patient is starting. We know that he's got fairly significant disease, fecal calprotectin in the thousands, getting worse after a steroid course. And so I think that, again, there are a few potential paths that we could take with this patient. That being said, he doesn't have any big red flags for me that would require an anti-TNF initiation out the gate. So I probably would withhold that until later in his disease course, should he need it. And again, this is a patient where I think an IL-23 inhibitor actually would be most appropriate. It's a great first-line agent, excellent safety profile. We know it's going to be effective and durable and work fast for him. This is likely not a patient where I would want to initiate vedolizumab, given how sick he appears to be, and also has primarily ileal disease. And typically, even though we have label changes with upadacitinib giving us a little bit more broad usage, I still am not typically using that first line.
All right, and then let's go to Ed, but listen to Ed on vedo as first line, even though he doesn't choose it, and then we'll show you one study that looks at vedolizumab first line for Crohn's disease.
So case 3 is a guy with Crohn's who has had recent increased symptoms. He's worried about the effects of steroids. He's been on budesonide. He has definite evidence of inflammation. His fecal calpro and CRP are high. He's got an SES-CD score of 12, which indicates at least moderate activity. And previously, I mean, here things are wide open because they're advanced therapy naive. Of the choices listed, I would be considering either veto, an anti-IL-23, or an anti-TNF agent. I wouldn't probably pull the trigger on upadacitinib this early, and I wouldn't be doing thiopurine monotherapy anymore. I also wouldn't be doing 5-ASA since this is Crohn's disease. And so of those options, the two that I would be most in favor of would be either the anti-interleukin or the anti-TNF. Again, probably if veto is going to be used in Crohn's disease, probably the best time to use it is in a patient like this who's advanced therapy naive. We know that from the LOVE-CD trial, that's when veto works the best in Crohn's, is in a patient like this. So those are three options. I'd be leaning mostly towards the anti-interleukin or the anti-TNF. Out of habit, probably, I've been doing more anti-TNF, but now we have so many options available. Anti-interleukin would be a great option too.
And another thing, if you did use an anti-interleukin first as a systemic therapy, you are open to use upadacitinib after that. We wanted to show you this. This was just published, so many of you may not have seen this study. And this gets to how does veto work for first-line Crohn's disease? And this, Brandon's case is perfect for this. One, it's a bio-naive. Second is it's early after diagnosis. That is the key important factors. And you can see early Crohn's is the dark, the blue is late Crohn's. And you can see a separation that if you were to use veto as the first-line therapy early, there are efficacy data in Crohn's. So to be completely fair balanced, if you were to use veto for Crohn's, use it as first-line very early. That would be my take-home. You heard before when we talked about infliximab, again, whether it was intolerance or failure, but veto after an advanced therapy, certainly in Crohn's disease, would not be appropriate. And I think you can even see in the late group, some of those patients had been on other therapies. What did ChatGPT say? Also picked a TNF inhibitor. So I think, again, the majority still picked that.
The best next step is option.
And we're not going to listen to that. And then the case perspective, it's really a split here. And I guess one question I want to ask the group before we have you all vote again, and then we'll get to some of the questions. Ed kind of mentioned this, and I think as we all become more familiar with an IL-23, is there a reason in this kind of patient that we would not just say we're using IL-23 first? The data look very good. There's not a head-to-head yet in the designed way we want with IL-23 compared to a TNF inhibitor like infliximab. Again, if you really were to be fair balanced, that's the trial you want. We don't have that. The safety is so good with an IL-23, the efficacy is so good. Is there any reason we shouldn't be using IL-23 first line? So I'm going to ask each of you the same question, maybe go down the line. Anita first and then Angelina.
Well, I wanted to go first this time, but go ahead.
Go ahead.
No, okay. I still
All right, go ahead.
All right, yeah, so I'm going
You actually
She
look
got
like
so excited. I don't want to take that away from her.
newscaster. We realized with the headset and the way
Yeah,
your jacket
I know.
is. So,
I know.
so go ahead.
All right,
Go ahead, Angelina.
sportscaster, newscaster. I think, you look chic.
I have to be very careful what I say. So just go ahead.
Exactly.
And answer
Exactly.
the
We should-
question,
we should
because a
stop
few
here.
things
Yeah,
popped
exactly.
into my head.
Okay,
but
okay.
We have a lot of people.
All
in the
right, I
virtual
still
audience,
think
so-
in a situation of more severe disease, closer to hospital admission, deep ulcerations, I would probably favor infliximab azathioprine combination therapy. I do like the UNC folks. I do use combination therapy of anti-TNF and immunomodulator in that situation. So if these were deep ulcerations, there's a significant, I know there's some data on stricturing disease and ability for IL-23 in stricturing disease, but even still, I think that I would favor in a sicker looking patient and even more severe disease, and ileal disease as well, because ileal disease, we didn't talk about this, but that's another beast of another phenotypic beast, I think, in treatment. I would favor infliximab azathioprine in a sicker
So the
patient.
sicker patient, and then maybe Anita, in a patient who maybe doesn't have the ulcers, we didn't talk about perianal disease, doesn't have perianal disease, why would you not pick IL-23 first? Or is that your go-to now for a patient with Crohn's ileocolitis?
Yeah, so it still remains an IL-23 as a go-to for the naive patient. One thing I wanted to highlight, and maybe sicker, and that's what I was emphasizing as far as that burden of disease that the patient is suffering from. We will here soon have results from Fusion, which is the guselkumab perianal fistulizing disease. And so that's going to be really great to see, because at present we only have that kind of level of studies with infliximab. That's why we always think perianal disease, infliximab, right? So I didn't fully answer your question, but I would still consider that in this patient, so as long as the factors that Angelina pointed out.
And then Ed, would you still use infliximab azathioprine? Say it's, again, not deep ulcers, no perianal disease, moderately active Crohn's ileocolitis. Is that still your first go-to, or are you starting to use IL-23 more?
Yes, so I don't think IL-23 is wrong, and earlier we were just giving the one-word answer, but so it's hard to sort of elaborate, but I think in this particular case, so I'm using IL-23 more, that's the answer to your question. The rationale in this particular case is, if I think about this guy that's really only had disease for a short period of time, this is not profile where it's 12 days.
Right.
But it's probably as close as we're going to see in practice in the United States, and he's already been on budesonide, and his fecal calprotectin went up. So maybe he's the other arm of profile, and those patients still had some of the highest remission rates that we saw in any clinical trial in the step-up arm. And so he's sort of the steroid step-up arm. They got to like 60% at 6 months, and the other arm was 80% at 12 months. So that's sort of how I rationalize this particular case.
Yeah, and just to be clear, we didn't outline the profile study. For anybody who has journal clubs, you should do the profile study. It's a European-based study. Within 2 weeks of diagnosis, so not a few months, a couple of years, 2 weeks of diagnosis, top down with primarily infliximab azathioprine versus step up. And to Ed's point, we saw some of the highest remission rates we've seen of any study. And what I want to bring up on this slide is, and I'll say this with absolute fair balance and objectivity, I think a newly diagnosed Crohn's, until we have head-to-head data, it may not matter what therapy we use as long as we use it very early and know that we need to monitor and switch. The reason I asked the question about IL-23 with the safety profile being so good and now seeing endoscopic improvement in efficacy, and now the fact that I can go to upadacitinib as the second line, I am tending to use IL-23 first. And just to answer a question I asked the panel before, I am using guselkumab primarily because the subcutaneous induction is so easy for me to start, and they can stay on it without getting a second payer approval at the maintenance dose. So just to be clear, it's not a head-to-head efficacy amongst IL-23s, and if you used another one, that would be perfectly acceptable based on efficacy, but because of the subcutaneous induction. Anita, you want to make a point? And then as you're making the point, if the audience can respond again in terms of what you would do for Brandon, this new onset Crohn's ileocolitis patient.
Yeah, my point was mostly with the anti-TNFs in a young patient, and certainly for any patient. First of all, when I start an anti-TNF, I always, at least for the majority, do combination therapy, right? So for that first 6 to 12 months, I'm doing combination therapy, unless there's contraindications, older patient, et cetera. So with that said, in a young patient, new diagnosis, burden of disease, quality of life, everything else, I want to, again, going back to that easy button, how do I get him back to feeling normal? That's the word that our patients say. When do I get to go back to feeling normal? So that's another reason why I would not consider an anti-TNF because I do combo therapy.
Right, so that kind of speed of onset. So points very well taken. Before we get to your questions, answer this. Maybe they already have. If they have, please put up the bar graph. So we do have a few more people saying they would use IL-23 first line, And then I still think in kind of second place is TNF. UPA kind of dropped off. I'm happy to say this again with fairness that mesalamine dropped off. I'm happy to see that. And then Veto, again, there's still some that would say that's okay, but really it's coming down between the IL-23 and the TNF. I'm going to finish out the slide parts, but now I have a lot of questions that I'm going to get to. Somebody asked me what I would do in Brandon's case, and I think I answered it already, but I'll say it again. I would use an IL-23 because if it were not to work, TNF's still an option, upadacitinib's still an option. Because of the ease of subcutaneous induction, I am using guselkumab, not because it's better than risankizumab or mirikizumab. There are no data head-to-head, so just to be fair, but because of the sub-Q. So I think we covered some of this, uncontrolled disease demands and not delaying. Mechanism matters. We are seeing IL-23 as a class. Efficacy alone is not enough, so we have to consider the patient, route of administration, safety, and kind of the right therapy for the right patient. These are kind of the SMART goals that we covered already, but improving your confidence in using these different therapies. Shared decision-making, which I think obviously you heard from our patients in our cases. The IL-23 class, which I think we are seeing starting to rise as an earlier and first-line therapy. And then obviously avoiding steroids and getting that clinical remission. I am going to show you the additional resources because I want to make sure that you get this, and then I will end with the questions. So first of all, please visit www.cmeoutfitters.com for clinical information, other programs like this. This is an important resource, and similarly, free resources are available. To claim your credit, I'll leave this up here for a second, and maybe we'll start asking some of the questions, but you can take out your phone, scan the QR code. Whether you're on live stream, obviously use the QR code at the bottom. Those in the room, use the QR code at top. And I'll leave that up for a minute, and then we'll ask some questions that have been coming in. So these are really, really good. In terms of, Anita, I'll start with you, pregnancy. There was a question that, and I don't know that we have the answer specifically. Can you cite the number of patients based on trials treated with Veto or IL-23? I don't know that I can tell the absolute numbers of patients that have been treated across the trials, but maybe contextualize. I think the question gets at Veto was an answer that people are using because people are comfortable, it's been out longer, and maybe the question's getting at what are the patient years follow-up, which I actually don't know the answer to that, but I don't know if you have any insight on that.
I don't know the exact number, but certainly the quick way to look at it is monoclonal antibodies are monoclonal antibodies. So the science molecularly is the same. Call it vedolizumab, call it guselkumab, call it infliximab. They're monoclonal antibodies. So from a pathophysiologic standpoint, the impact to the placenta, to the fetus, to the baby, and to the mother are equivalent. So we could be able to interpret as such.
Good. Yeah, I agree with that. Angelina, and then I'll flip to the very last slide just as far as how you can kind of claim your ABIM and mock credit. Angelina, you mentioned LFTs and IL-23. Completely agree. One of the questions came up, which is interesting. Do you switch patients from one IL-23 to another if there is persistent elevation in LFTs in the first IL-23?
I haven't done that. I haven't personally done that. I would want to make sure that in the scope of this, that what you're really doing is when you are witnessing an LFT elevation, I mean, it's really important to kind of classify this. Is this mild? Is it less than 3 times upper limit of normal? Is it greater than 5 times upper limit of normal? I mean, it's really important to understand the severity in which this is occurring. The second thing you usually want to do is make sure you really understand, is it really drug-induced, right? Is this a really drug-induced situation? Is it getting a little bit more hazy where there may be multiple factors, alcohol, MASH, something else that's going on as well? So those things probably matter first before I do anything differently. So one is to make sure, the bottom line is make sure you're attributing the LFT abnormality truly to the drug if you're thinking about switching to another. I think that's the best way I would answer it. I haven't done that personally. I think it could be, I mean, it's possible that when you withdraw the first drug that you might see the liver enzyme normalize. In my experience, when I have seen, like you had mentioned this earlier, it's a transient liver enzyme elevation of what I have seen. It usually doesn't last beyond the induction period. That's typically when I've seen it, and it's very mild. I don't even think I've seen one greater than 2 times upper limit of normal in my experience. And they do normalize.
Yeah, and I think the bottom line is we don't have data switching IL-23 one to another, just to be clear, agree with you. The other is the LFT abnormality that I look out for with any medicine, but I'll say with IL-23, as long as it's not 3 times upper limit of normal, above that, I still monitor the patient. And as Angelina said, look for other reasons their LFTs might be elevated. If it's persistently 3 times or it's gone above that, I do stop that therapy. IL-23 would be one. And if that did happen, I wouldn't switch to another. Ed, there were some questions on perianal disease, specifically hidradenitis, which is out of the context of what we talked about. But let me maybe ask it this way. For the question that was asking, hidradenitis, any data on IL-23 versus TNF, which obviously there's data, but a patient maybe who failed a TNF. And then perianal disease in general, you kind of answered this already, but what's your first line, second line therapy?
Yeah, so I think I'll go to the second question first, because I think Anita alluded to the fact that we need these data to be published, and I think that's going to be very helpful to have that, because most of the perianal disease data that we have is in the form of post hoc data from large trial programs, and so having dedicated studies is going to be very helpful. So sort of putting it in order right now, I think we have infliximab as a go-to if they haven't been on infliximab, and then it does come down to a JAK inhibitor, IL-23 in my mind. Even though there is vedolizumab data that's been published for perianal disease, I just haven't found that to be as efficacious or as effective in the real-world practice. To the point about hidradenitis, I think this is a really interesting question. And so in a patient that's been on an anti-TNF that then is not responding to that anti-TNF therapy, and they have bad hidradenitis in the setting of IBD, this is where I think, going back to the difference between being in an IBD center and having to have a challenging patient like this in practice, I'm really lucky because our dermatologist that manages hidradenitis happens to be one of the go-to people in the country. And so he has trials for this. He will put people on combo, if not tertiary, advanced therapies, and he's injecting with methotrexate, and he's doing laser therapy weekly. So I think this is where I can't tell you there's an algorithm for this, and I think it would be try everything, because these are among the most refractory patients that we have. And so that's the most unreassuring answer that we'll try to give you on the panel.
I was going to say, Ed, you're not making me feel better, and I'm not sure.
I think we have to go to UNC.
Except go to UNC to get.
No, but my point is, I think once you get beyond standard of care for hidradenitis, you try anything, because this is so debilitating for the patient. So you just try everything that you can, and that's what I've seen Dr. Syed do.
Yeah.
So I think one thing with hidradenitis, and then Angelina, I'll call on you. Sometimes perianal hidradenitis is difficult to distinguish from perianal Crohn's disease. Obviously, if a patient has axillary changes of hidradenitis in certain other areas of the body, there might be some features that look like hidradenitis, but sometimes we can't tell. Mm-hmm. Like Ed said, I think TNF inhibitor is first line, but then when you get beyond that, probably getting specialists involved. But Angelina, your thoughts?
Well, I was just thinking the same, but I also wouldn't have any concerns with putting someone on an IL-23 if they did have HS either, to see if it would improve things, given that it has favorable, skin effects as well. So I think, again, I agree tremendously. This can be extremely challenging in the management and improvement.
So,
And then there are a few case series and studies with IL-23s as well as with JAKs to study and evaluate its role and efficacy in HS.
yeah, and I think we've all used probably all the agents. Generally, our dermatologists love IL-23, so if I'm going to send a patient to the dermatologist, I'll start an IL-23 first, because if we didn't, they're definitely going to do that. So if we've done that already, at Ed's point, then you get into additional. therapy. Anita, people picked up on a comment you made, and there are a number of questions related to speed and rapidity of onset. I didn't show any graphs or data, and I know you were involved in some of the IL-23 studies, especially guselkumab. Talk a little bit about, not only in the data, but in your practice, what you're seeing as far as rapidity and speed of onset with IL-23.
Yeah, so we're actually impressed with the level of rapidity that we're seeing with the IL-23s and with my familiarity and involvement with our Galaxy trials, but then we're also looking at Gravity, which is the sub-Q formulations, and Quasar, and looking at rapidity in totality, whether it's UC or Crohn's disease, finding that our data, even though our initial endpoints for Crohn's, be it 8 or 10 weeks or whatever it might be, we were still already seeing the separation even as soon as within week 1. And so that kind of rapidity is what we had not previously seen with some of our other therapies, and that's where the reassuring component came in.
Perfect. Ed, this is an interesting question. I'm going to ask you a question about high BMI, sub-Q guselkumab, IV guselkumab. And then, Angelina, I'm going to ask you a question that keeps coming up, but how do you determine which IL-23 you use first? But high BMI, does that make a difference for you in terms of using sub-Q versus IV? And Anita has data, can she presented it, but I'll ask you first.
Yeah, I mean, I think that it's a consideration. I think that this has been a consideration, even if we think about anti-TNF therapy and the idea that some of the trials were done with, double dosing of adalimumab, for instance, and trying to do higher dosing. So I think it definitely is a consideration. Whether or not I think every single patient has to be on an IV approach if they have a high BMI is I think not necessarily something that I would do in practice because of some of the accessibility issues that we talked about before. So I'll sort of give it a short answer because I know we're short on time.
And then Anita?
So we looked at PK data of IV formulation and sub-Q formulation and utilized and studied different factors and variables. And actually BMI did not influence the bioavailability, meaning you could give sub-Q despite their BMI.
And if you look at the interquartile BMI high and then down the 3 quartiles, sub-Q and IV were indistinguishable in terms of efficacy. So kind of that thought, Ed, of we have to use IV for high BMI, we didn't necessarily see that. Which IL-23 first and why? Again, I know we've answered it, but answer it maybe one more time, Angelina.
Yeah, I think this is where you want to use, if there is head-to-head data, I think it helps a little bit just thinking, well, let me say it differently. I use the data from Sequence, I use the data from the guselkumab study looking at ustekinumab and seeing that both of those studies showed superiority to Stelara. And then looking at mirikizumab having non-inferiority. So to me, that's showing something's a little bit different here. Whether this makes any sense or not, I don't know. But in my mind, that is something, those are some things that I'm thinking about. I like for a lot of the patients, and except for the few that are needing IV, the sub-Q induction dosing has been really helpful in a lot of ways. So lately that has been a go-to for me. In the end, we don't have head-to-head between, say, risankizumab and guselkumab, so I can't necessarily say this is the one to use. So I think you're good in thinking about what can you get for your patient. We don't want to have delays in therapy because of some small thing. So getting a patient on drug quickly with patient assistance is fantastic. And so for me, it's often been that I've been writing quite a bit of Gus lately.
And then Anita, same question. I know you've said it before, but any differences in what you said before?
No.
All right. And then I'll end with one question. Anita, I'll come back to you, and Ed, I'll end. We can't get through any program without talking about GLP-1, so thank you. There were a bunch of GLP-1 questions. Just for the record, we don't have enough data. Ed, you might talk a little bit about the pouchitis data with GLP-1s. One, Anita, is there any problem using any of our therapies in a patient on a GLP-1? And 2, are you using GLP-1s to treat IBD specifically? Completely off-label, not part of this actual program, but just to ask those 2 questions.
Am I using GLP personally? No, I'm kidding.
I didn't say that.
Are you calling me fat?
Record.
So no harm in continuing or starting or initiating appropriate therapy for your patient, even if they're on a GLP. In fact, you're probably going to have better outcomes because we know obesity and some of those other medical comorbidities related to that. If we could improve that, because obesity, fat, adipose is inflammatory, we're also seeing better benefits in disease control. In fact, I believe mirikizumab actually has a trial and study with a GLP and Miri, or they're evaluating. I don't know if that's taken off. Your second question, as far as to use it as a solo, no.
Okay. Ed?
Yeah, no, I totally agree. And I think that, the specific way that we have used the GLP-1s, and this comes up in our pouch clinic, is that aside from the inflammatory component, patients that have an ileal pouch anal anastomosis have a J pouch often have high bowel frequency that's separate from actually the inflammatory component of having pouchitis or Crohn's-like disease of the pouch. And what GLP-1 is mediated in is the ileocolonic break. So if you don't have a colon anymore, then obviously you lose that, and that may be one of the drivers of high bowel frequency. And so GLP-1 receptor agonist therapy can actually help in slowing down bowel frequency. And so we did a small pilot trial at UNC where Hans Herfarth led it, where patients were on active therapy and randomized to placebo, or placebo and randomized, and they were self-controlled, randomized to the active therapy, and showed over a 30% decrease in bowel frequency during a very short trial. And so we've now used that to then get approval for these therapies in a large proportion of our patients in our pouch clinic.
But just again, fair balance, we're not recommending GLP-1 as a sole treatment for IBD, but we are completely comfortable if a patient's on a GLP-1. And as Anita said, there are studies that are now being designed to use GLP-1 as part of the therapy for IBD. Ed, Angelina, Anita, thank you. I thought that was very interactive and excellent. To the audience in the room and the audience online, thank you for so many questions. Sorry we couldn't get to them. For those here, enjoy the rest of Congress. And I know with the snowstorm out there, I wish everybody safe travels back. See you around.
Thank you.